everyone. Welcome to day 3 of the Preemie Health Talks. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, CPBF, and your host for this event. The Preemie Health Talks is the first international live series that CPBF is hosting in 2021. These educational sessions are in collaboration with the Family Integrated Care Committee, the Canadian Association of Neonatal Nurses, the Canadian Neonatal Network, the European Foundation for the Care of Newborn Infants, EFCNI, and GLANCE, the Global Alliance for Newborn Care. For those not familiar with CPBF, we are a charitable organization, and our mission is to empower families of premature babies every step of the way through support and education. We believe that through consistent information, access to helpful resources, and peer support inside and outside the NICU, we can empower families, ensuring they are ready to care for their babies. For this Preemie Health Talks, we brought health experts from around the world and all over Canada. We have been diving deep into topics affecting preemie health, from breastfeeding to parental mental health during the pandemic, from the importance of kangaroo care and best practices to protect your baby's skin. If you need closed captioning, you can watch it live from our YouTube channel and enable closed captioning on the screen. I want to thank our sponsors, Medela, Water Wipes, and Prolacta Bioscience for their ongoing support. Please use the comment area below your screen to ask questions, to share your perspective and stories. Today we have 2 presentations. The first one by Dr. Johanna Kostenzer on the global impact of COVID-19 on neonatal care from the parent's perspective. And also, we're going to have Dr. Pablo Duran talk about early nutrition and the impact on the life course. And right here, we're going to start with Dr. Johanna Kostenzer on the global impact of COVID-19. And let me just bring her to our screen. Here you go. Hello. So this is the global impact of COVID-19 on neonatal care, the parents' perceptions. The COVID-19 pandemic has created exceptional challenges, especially for the care of the most vulnerable groups of patients, such as sick and preterm born children in need of special or intensive care. In the course of the pandemic, several measures were taken to reduce social interaction and the risk for transmission, but especially also in hospitals and neonatal intensive care units. Restrictive measures were implemented. This talk will focus on the impact of the COVID-19 pandemic on special and intensive care for newborns by discussing recent results of a global study exploring parents' experiences during the pandemic. And joining me live from Munich, Germany, Dr. Johanna Kostenzer, who is the Head of Scientific Affairs at the European Foundation for the Care of Newborn Infants, EFCNI. Her current projects focus on the impact of COVID-19 on neonatal care and on the need for regulation of donated human milk in the European Union. With her academic expertise in the field of reproductive health and health governance, Johanna supports EFCNI's mission to pave the way for the best start in life. Dr. Kostenzer, thank you so much for joining us here today.
Thank you so much, Fabiana, for inviting me. I'm very happy to be speaking here today on behalf of EFCNI and on this particular topic.
That is great. So I will let you share your screen. So I know you have a presentation to share with us. And for all of you watching us live from Facebook or YouTube, please send your questions and your comments that we're going to be addressing right after her presentation. And here you are. The screen is yours.
Yes. Again, thank you so much, Fabiana, for inviting me. I'm very happy to be speaking here today at the Preemie Health Talks. And I will speak on behalf of the European Foundation for the Care of Newborn Infants, which is the first European organization to represent the interests of preterm infants and their families. And by the initiative of EFCNI, the Global Alliance for Newborn Care, we started a survey and a study on the global impact of COVID-19 on neonatal care and explored the parents' perceptions in this particular context. And of course, today I will talk about this survey and also will actually for the first time also tell you a bit more about the results of this study that we have conducted. So I will briefly guide you through the next few minutes and the next half an hour probably. So I will first, of course, explain a bit more about the background of the study that we conducted, and then go into more detail of the findings of our study, and we'll focus here on different pillars of infant and family-centered developmental care. And in the end, of course, I will also give you some conclusions and a take-home message for this talk. So first, what I would like to share with you is a global overview of preterm birth in all different countries that you see here on this map by the World Health Organization. So to say it in general, preterm birth and preterm birth related complications are the leading cause of death for children under 5 years of age. So this, of course, is a very major factor and a very important field of care that needs to be taken care of. And together with infants that are sick or that are born at a low birth weight, this group is a very vulnerable group of patients that requires special attention, special treatment, and is, of course, also a difficult patient group in that sense, as it is such a vulnerable group and also the youngest group of patients in general. So what we now saw in the last year was that there was, because of the COVID-19 pandemic, a strong impact on, all different industries and sectors, of course, but also in particular on the healthcare sector. So this pandemic created severe challenges for different aspects of the healthcare sector. However, also particularly on neonatal care and on the care for these very vulnerable and these very young infants that require special or intensive care. And what we saw because of this pandemic and also related restrictions that were implemented because of the pandemic was that many hospitals and healthcare organizations implemented separation policies during this COVID-19 pandemic. So that means that worldwide, many neonatal units have adopted separation policies, which means that they limited or even prohibited access of parents to neonatal care units. So this means that parents were not able to be present with their newborn in the neonatal care units. What we also know from research is that separation can result in long-term health and developmental issues in newborns and can also impact the mental health of the parents. So the separation does not only have an impact on the development for the infant or infants themselves, but it also has negative impacts for the parents and the family as a whole. What we also know from very recent research is, however, that the survival benefit of kangaroo mother care, and kangaroo mother care is this very close skin-to-skin contact, far outweighs the relatively small risk of death due to the COVID-19 infection. And here, of course, I need to put this in context because small risk of death due to COVID can also be misunderstood. But what we mean here is that this is a small risk of transmission from the parents to the infants in the neonatal intensive care units. So this risk is very, very small, and prohibiting access or prohibiting kangaroo mother care is out of context in this regard and is disproportionate when we consider the relatively small risk of transmission and then also death due to the COVID-19 infection. So these are all facts, but what we also know is that many parent organizations that we are in contact with and that are in our network have had very severe experiences with regards to the involvement of parents in the care of their preterm, sick, or low birth weight infants. So here I really have to mention that ever since the pandemic started, and particularly started also in Europe, so from early 2020 onwards, we had regular meetings with parent organizations, so of course digital meetings. And in those meetings, the parents told us what the situation was like in their countries. And they told us that parents were separated from their infants so that the parents could no longer be present with the infants in the neonatal units. But also there were other effects in terms of that the partner, for example, could not accompany the mother or the to-be mother-to-be when going to prenatal care appointments and so on. So there were very strong policies all of a sudden in place. And of course, we knew, okay, this is this is anecdotal evidence. So these are stories from parents that are being told, but we really need hard facts in order to know what's happening and what's going on. And that was actually also our incentive and impulse to dig a little deeper and to explore the parents' perceptions and the parents' experiences with regards to the implemented measures due to COVID and the coronavirus. So this led finally to the study that I will now be presenting. So the title of the project, so to say, is Impact of Coronavirus COVID-19 on Special Intensive Care for Newborns, a Parent's Perspective. So what we did with the study was to explore parents' experiences related to all these challenges that were caused by the pandemic and actually by the pandemic-related restrictions that were put in place in neonatal care. And we did this with a global and multilingual online survey. So we set up an online survey that was later also translated into 23 different languages, because we really aimed for a global outreach and an outreach in many or as many countries as possible. And I also have to say a big thank you at this point to all the parent organizations all across the world who helped us translating this survey into so many different languages. In the end, the participants of our survey were actual parents of sick or preterm born infants who were born in this timely context of the COVID-19 pandemic. And here we focused on this first year of the pandemic. So that means that we asked parents of children who were born between the 1st of December 2019 until the 30th of November 2020. So that was also the point when our data collection ended. We did not do the study completely on our own, so we also had a few collaborating organizations who supported, for example, also the setup of the survey and gave feedback on the survey and the questionnaire. And these collaborators were, on the one hand, COIN, so the Council of International Neonatal Nurses, ESPR, which is the European Society for Pediatric Research. Also, the NIDCAP Federation International supported our project, and finally also UNPS, which is the Union of Neonatal and Perinatal Societies. So those 4 collaborating organizations, together with many parent organizations, helped us in the setup and also in the dissemination of the online survey. I also need to mention at this point that we received an earmarked donation by Novartis in support of this study. However, Novartis did not have any kind of influence on the study. It was simply an independent donation, and we at EFCNI, and in particular the scientific department, completely independently worked on this survey. To give you a short intro into the questionnaire itself, so what kind of questions did we actually ask? So, of course, on the one hand, we asked for COVID-19 related questions. So, of course, for example, if there was an infection and other questions in that field. We also asked questions in the field of prenatal care. So, for example, if appointments took place on a regular basis or if there was some sort of changes due to the COVID restrictions. We also looked into the topic of breastfeeding and nutrition. We asked questions with regards to parental presence. We also asked questions with regards to communication, and here in particular with regards to health communication. And also we focused on the topic of mental health and support. And all these questions and topic areas are part of infant and family-centered developmental care. So this was also the overall concept that we used for the setup of our questionnaire and for the setup of the survey in the end. The participants who could then finally take part in the survey were, as I already mentioned, the child of the parents had to be born on 1st of December 2019 or later. We chose the 1st of December because this was also the date or the approximate date when the first COVID case was identified. And also the baby of the parents had to be receiving special or intensive care. So we really exclusively focused on infants that were either born preterm, of lower birth weight, or that were sick and that needed this special care. And also the respondents had to be the parents of the baby. So we really exclusively wanted to look into the parents' experiences with regards to neonatal care. Finally, in total, we had more than 2,100 respondents from 56 countries all across the globe, who were then finally also included in our analysis. And on the next slide, I would like to give you a short insight into what the country overview looks like. I apologize for the graph. It's not very sharp, but I hope you can still see the most important things, which are simply that there is, of course, strong variation across the countries in terms of the response. So what we see immediately is that one country, and as we see here, Turkey, has more. Here we had more than 300 participants, and also in some other countries we had more than 100 participants. For example, in France, in the Netherlands, in Poland, but also in the Ukraine. And in some other countries, or many other countries, we had between 30 to 50 respondents, and so there's of course a strong variation, I would say. But overall, as I said, we have more than 2,100 respondents from many different countries, and we're actually very happy with this response because we also need to consider the very sensitive target group that we have for this study, because it's not only parents of newborns, but it's parents of very vulnerable newborns, and probably participating in a study is not their priority number one. So we also need to keep that in mind, and are very happy for every parent who took the time to take part in our survey. Yes, but now is actually the time that I would like to share some of the results and some of the very first results of our study. Because here I also need to mention that our study has not been published yet. So we're at the moment finalizing the first manuscript, and it's in internal review and will soon be submitted, and hopefully then also soon be published. But also just keep this in mind that it's still unpublished findings that I'm going to share. What I will share with you now is some findings from 4 different pillars of this infant and family-centered developmental care. So I will focus in particular on parental presence, on Kangaroo mother care and skin-to-skin care, on the topic of breastfeeding, and on mental health and support. In our study and survey, we of course also focused on different topics and different areas, which are in the end all interlinked. But for this presentation and this talk, I chose those 4 because the results might be of great interest also to the audience. So starting with the first one, I will first always show an infographic with some more general information and some scientific evidence before I will then also go into more detail about the findings of our study. So looking first into parental presence. So parental presence means the presence of the parents with the newborn or with the preterm infant in particular in general, but also then in the neonatal intensive care unit. So parental presence, as you can imagine, and as you probably know, has a lot of benefits for the development of the infant and also for the family and family bonding as a whole. Many studies show, and in particular this one meta-analysis shows, that single family rooms, for example, decrease the risk of sepsis by 37% and also increase breastfeeding rates at the time of discharge by 31%. Furthermore, in neonatal wards, where the mothers were not able to be with their baby on a daily basis, 29% of these children had behavioral problems at the age of 7 to 8 versus 0% if mothers were present every day. So this also shows that the presence of the mother, but also of the parents in general, has very strong benefits for the development of the infant. And finally, also, parent empowerment in the NICU decreases parental stress, depression, and anxiety, and leads to shorter NICU and hospital stays, and consequently decreases also the costs to society. So what we learn from these facts is that, of course, parental presence has a strong benefit for the infant, and especially for the vulnerable infant in terms of development, but also it has a lot of benefits for the families and the parents in particular, also with regards to mental health. But what did we now find in our study? So here I would like to share a few results and a few messages from our study and our findings. One is that approximately half of the respondents from our study were not allowed to have another person present with them during birth. So that was like the first part that we looked at, what happened during birth. And here, almost half was not allowed to have someone else with them. So that also means that they were alone, the mothers were alone. I have to mention at this point also that in some countries, this has also, of course, been the case before the COVID pandemic, especially when we look at C-sections, then it's often the case that the mother is alone. So this is also one limitation of our study, that we cannot really compare before COVID and during COVID. But I still wanted to show this because, 50% is, of course, a lot. What is, however, also very interesting is that 70% of our respondents stated that the mother was allowed to be present with the baby, and 56% of the fathers or the partners were allowed to be present with the baby. And on first sight, of course, what we see is, 70% and 56%, that's actually quite a lot. But we, of course, need to look at this from the other side. That also means that 30% of the mothers were not allowed to be present with the baby that was receiving special or intensive care. And also 44% of the fathers were not allowed to be present. These are, of course, shocking results. And what is even more shocking is when we see it like this, because in the end, in one out of five cases, nobody was allowed to be present with the baby. So that means the baby was alone in the neonatal intensive care unit, and alone, of course, meaning without the family, without the parents. So also no other family members was allowed to be there. What we also found, that while 40% of the respondents had unlimited access, so that means that they could be there all the time or there were no restrictions, 30% were only permitted to be with the baby for up to 1 hour per day. And finally, half of the participants were not offered any alternatives to being present with their baby. So this is in many cases actually quite common, to at least then provide photos or videos or live stream or at least phone calls. But in half of the cases, there was no alternative to being present with the baby. I would now like to focus on the next topic, which is kangaroo mother care and skin-to-skin care. And also here, there is a lot of scientific evidence for the benefits of kangaroo mother care and skin-to-skin. So of course, a very close contact with the mother has strong benefits for the development of the preterm, low birth weight or sick infant. On the one hand, kangaroo mother care, for example, reduces the mortality by 40%. It also reduces infection and sepsis by 65% and hypothermia by 72%. So the benefits in that regard are, I would say, very clear. Kangaroo mother care, furthermore, has significant, long-lasting social and behavioral protective effects on a preterm baby, even on a long-term basis. And also, skin-to-skin contact with the mother and the baby enhances the general stability of the child, resulting in less stress, better sleep, and cognitive control across the first 10 years of life. So in general also, skin-to-skin care decreases the cortisol level in mother and baby. It also reduces parental stress, depression, and supports breastfeeding. So as we see from this infographic, is that skin-to-skin care, which also includes kangaroo mother care, has many, many benefits for the development of the child, but also for the family bonding, and also reduces stress among the parents. So again, what did we find with our study? What we found that almost 80% of the respondents were allowed to touch their baby in the incubator or the bed, and half of them as often as desired. And again, here we see 80%, that's really a high number. So the first impression would be, that's really good actually. But again, we also need to see it from the other side, which means that in 20% of the cases, the parents were not allowed to touch their baby in the incubator or in the bed. And this, as we learn also from the facts, it has strong negative effects then also for the development of the baby, but also for the parental bonding with the child. What we also found that in more than 50% of the study participants and the cases, they stated that skin-to-skin contact was initiated after the first week, after discharge, or not at all at the time of data collection. So that also means that in the other 50%, it was initiated before the first week or during the first day even, but in many cases it took quite a while until skin-to-skin contact was actually initiated. What we then also learned from the study is then in approximately 1/3 of the participants was allowed to have skin-to-skin contact as often as they wanted. So 1/3 was really on the, as much as you can say, good side of life in that regard. However, also on the other side, 2/3 of the participants were not allowed to have skin-to-skin contact as often as they wanted. Looking into breastfeeding, I think here it's, of course, the benefits of breastfeeding are, of course, quite obvious. And I think I don't need to go into too much detail here, because the benefits of, in particular, exclusive breastfeeding for the first months of life have not only been confirmed by the World Health Organization, but also by many, many organizations and healthcare professionals. And the benefits are actually undisputed. What I would like to mention at this point, however, is that we, of course, need to be aware that breastfeeding is not always possible. So even though it is the gold standard, in particular for preterm infants or also sick and low birth weight infants, breastfeeding is sometimes not possible because the infants are not yet able to be breastfed, or also on the other hand, because the mother is not able to breastfeed because lactation has not started yet, or for many other reasons. And of course, also there are sometimes cases where the mother does not want to breastfeed for other reasons, which also needs to be respected. However, of course, breastfeeding and human milk and mother's own milk, so to say, has a lot of benefits. It decreases infant mortality, but it also decreases the risk for necrotizing enterocolitis, sepsis, or infant mortality, and is therefore very important for the development of the child and also for the mental health outcome and movement development of a baby. What we found in our study was that in general, breastfeeding was supported quite well also during the COVID-19 pandemic. So in more than 85% of the respondents, the infants were partly or exclusively breastfed or fed with their mother's own milk, which is either expressed or pumped milk, in the first weeks. We also found that the initiation of breastfeeding and the provision of mother's own milk took place mostly on the first day or during the first week after birth. And over 70% of the respondents were allowed to bring expressed milk. However, here I need to mention that this was not the case to the same extent in countries where quarantine was in place. So here we really see a difference between the level of restrictions within the respective countries. So the more restrictive the measures were, in terms of the more restrictive the policies were, for example, like quarantine or a lockdown, also, there were more restrictions on, for example, the bringing expressed milk to the neonatal intensive care unit. As a last topic that I would like to highlight here is I would like to explore a bit more on mental health and support. And here I unfortunately do not have an infographic, but as you can imagine, mental health and also support for the parents is also a very important topic and a very important field. Because what we do have is we have new parents, so parents of a newborn. And in general, of course, this is already a stressful and a life-changing event. But if we now consider also parents of infants who need special or intensive care, who are born preterm, who are sick or at low birth weight, these parents are under immense stress and pressure, also because they need to be at the hospital a lot and so on. And then also seeing this in the context of COVID-19, there is, of course, a big pressure on the parents. What we found that in almost 80% of all respondents worried to a high degree or to some degree about the COVID-19 situation during pregnancy and after birth. The respondents of our study worried the most when more restrictive measures were in place. So again, as we had it before with the breastfeeding topic, also here, the level of restrictions plays a role with regards to the mental health status of the parents. Half of the parents or the respondents that we have included in our study did not feel adequately informed and mentioned that there was no mental health support. And this support includes counseling, it includes self-help group or patient groups. And half is really, it's like 50%, which is also quite a lot. And it also means that there was really a lack of support for these parents. And finally, adequate information on COVID-19 protective measures was lacking when the parents or when the infant was discharged from the hospital. And that was for 40% of the respondents mentioned this. And here at this point, what I also need to mention is that, again, I of course need to put it in context, because the COVID-19 situation, and especially at the beginning of the pandemic, was of course a new situation for everyone involved. So that also means the healthcare professionals did also not have sufficient or adequate information. So of course they then could also not pass it on. However, what is really important to mention here is that we still need to be better prepared for future pandemics and for future emergency situations like this, so that we can then in the end also provide better care and also provide better support for the parents in general. But this actually already brings me to the end of my presentation, or to the final part of my presentation, with some concluding remarks and some summarizing remarks. Because what I would like to end this presentation with is a call for zero separation. And zero separation means that parents should not be separated from their newborns, because it creates more harm than actual benefit. So the COVID-19 related restrictions in neonatal intensive care units really severely challenged all the evidence-based cornerstones of infant and family-centered developmental care, such as, for example, separating parents and their newborn child, but also, as I mentioned before, also has impact on breastfeeding patterns. It has an impact on kangaroo mother care and skin-to-skin care, and also on mental health. So what we therefore call for is a zero separation policy, and also an immediate, sensible, and compassionate lifting of existing restrictive visitation policies in the hospital settings, and in particular in the neonatal intensive care units. What we need to do is plan for the ongoing COVID-19 pandemic, but also we need to be ready for future pandemics and emergency situations. And the findings that we have from this survey must be considered by public health experts, but also by policymakers alike, to reduce unnecessary suffering and deaths. And here I would like to thank you again, Fabiana, for inviting me, and also to the audience for listening. And in case you have any questions with regards to the study, then feel of course free to reach out, or also of course to ask your questions now in the Q&A session. Thank you so much.
Thank you, Dr. Kostenser. What a great presentation. You can stop sharing your screen so you can, yes, that's better. So thank you so much for shining the light on the situation worldwide in the NICUs. And it's heartbreaking that over a year later, we are still talking about this, and the restrictions still remain in a lot of hospitals. I think my first question to you is, did you see any variation between countries that are like developing countries? What have you seen in terms of variations by country, or even in different areas of the countries?
Mm-hmm. Yes, we do indeed see big differences. So what we did with our analysis was, at the first, we looked more into, are there any differences with regards to the level of restrictions? Because in some countries we had more severe restrictions during the first year of the pandemic, and in others we had very strong restrictions. So that's one difference we looked at. And now at the moment, we're also working on a second study, or a second analysis of the data, where we really look into country-specific differences. And here we also see strong variation across some countries. So, for example, in Australia or in New Zealand, what we see is that parents have not been separated from their newborn. So the policies were actually the same than before the COVID-19 pandemic, because this was apparently also a priority by the healthcare system, or by the health policy to keep parents and the infants together and keep them close. However, in other countries, we see strong interference into this parental presence. So as for example, in China, parents were not allowed to be present with their infant. So there was simply, there was a lockdown in all different aspects, also in neonatal care. And of course, this, as we know from the research, and not only from our research, but in general from science, is that this separation has a very strong impact and a negative impact on the development of the child. So this is really, also the reason why we call for this zero separation policy, because it creates more harm than benefit in the end. And so there is strong variation across countries.
Absolutely. Even here in Canada, we have variations in hospitals where even across the street from each other. And you have hospitals who never change the policy in terms of both parents being present, to hospitals that until today has a 3-hour limit for parents to stay with the baby, which is, okay, that's a year later. We have more evidence. We have enough PPE and, protocols in place to keep the parents and babies together. But I just want to bring our audience. I want to thank Joanne from UK from joining us here today. She's saying hello on behalf of Noah Star. We have Shakira. Thank you for your talk. And Inaya from Pakistan. Hello. Thank you so much, all of you, for joining us here today. If you have any questions or comments, please use the comment box below. So we have one more question here. Let me just take this out of the screen. What was the average length of hospital stay? Will they be able to show the longer in hospital or sicker the baby that could have an impact on their results on all your pillars?
Yeah, so we looked, or we will also look more into this. However, we did not make an analysis according to the length of stay of the infants. Also, because the data collection was, of course, one moment in time. So we also had parents or also infants of different stages of their hospitalization. So for some parents who answered the survey, the child was just born 1 week ago. And for the others, it was already in the past, so the discharge already happened. So we do have quite of a variation here, and we have so far not analyzed it according to today, because it's also it's probably a bit difficult to make. What we also need to consider here is a global study is of course great, but it also has some limitations because we did collect the data in many different countries at the same time. It was not possible to allocate for the differences in the pandemic. So of course, as we now know, the pandemic several waves throughout the last year, but we could not accommodate that in our analysis, because it was simply impossible to look into every country to see what kind of waves of the pandemic took place, and to what degree also that was really difficult to follow. And that's of course a limitation. Still, what we have with this global study, very good impression of the restrictions that took place, and also we can then draw conclusions for policymakers and healthcare professionals alike.
Okay, so we have actually 2 people asking here, how can you get a copy of the study once it has been published? Thank you, Joanne, for asking that. And I think same question from Sherry, how can we find out when this will be published?
Yes, so we will submit the study very soon and hope that it will also be published very soon, and we will also have a second paper out as well. And yes, thank you also for sharing the link to EFCNI. So what you can do for sure is to sign up to our newsletter, because of course the results will be promoted in our newsletter. And what is also very important for us is that we will have the publications as an open access. So that's for us very important to have the data out for everyone, because that's also our, I would say, responsibility in that regard. Because we only started with this survey because we were so inspired and also driven by the parents' experiences. So we then decided, okay, if we write this manuscript and have a scientific publication, we cannot have this in some library and hidden only for scientists, so to say, but this has to be public information. And this is also why we decided this needs to be accessed and available for everyone. So this is also why we will have papers published in open access in scientific journals. However, in addition, what we're planning for is a full report, including all the data for every country, which will then be available also on our website, and which is then for download for free for everyone who is interested and who is willing also to look into the information and documents. And we then also plan further activities around that, but that will only happen a bit later in the year. But yeah, as I said, just feel free to sign up our newsletter and you will stay informed and you will be able to access all the data and information on this study.
Absolutely. I'm just sharing the link again, but I highly recommend everyone to follow EFCNI or Glance's social media channels where they post a lot of information there. And also, we always amplify here at CPBF the message from EFCNI, especially when this publication comes out. We're certainly going to be sharing. Let me see if there is one more. Sherry said, thank you for advocating for parents and their children. So let's talk a little bit about the Zero Separation campaign before you wrap it up, because the Zero Separation campaign was launched in July last year, right at the beginning of the pandemic, when a lot of us parent organizations started having meetings constantly with FCNI, and we saw the restrictions in our own countries, and we decided to put this call to action together. So what has been the impact of the Zero Separation campaign so far?
Yeah, well, the Zero Separation campaign, as you already mentioned, was initiated last year, and it will also be continued for the next year, because we also see that the pandemic, even though we have vaccinations available now, it will not be over very soon. So we'll keep on focusing on the Zero Separation campaign. And what we see is that there is very strong interest in this campaign, and we get a lot of requests, not only from parent organizations who of course also share this mission and this interest, but also from healthcare professionals, from policymakers, from many different groups, also the media of course, who have an interest in this and who also feel with the parents in terms of the Zero Separation policy or the call for action, so to say. So there is great interest, and it has already been picked up by many organizations and people to support this message. And we of course invite everyone to spread the message, to spread and use the hashtag, because this is really at our heart at the moment, because Zero Separation, and we need to really be aware of this, this is not only a matter of COVID-19. Zero Separation has been an issue before the pandemic, and it will unfortunately also be an issue after the pandemic, because very often in many cases, in many countries and regions of the world, it's of course, or not of course, it is unfortunately a measure to separate the parents from the infant for a variety of reasons, because I don't know, perhaps the treatment is then easier, and so to say, or it's just a local policy. However, what we know from scientific evidence is that this is not good for the development of the child, and it even has negative consequences. So the Zero Separation policy is for us, EFCI, and for GLANCE, of course, it's not only related to COVID-19, and that's really a strong message I also need to bring across here, because it's also an issue pre and post pandemic. So
absolutely. Dr. Costa, thank you so much for joining us here today to share your knowledge, what you've learned for the last year during the pandemic. And certainly we have to continue to do this advocacy work because, as you said, this is beyond the pandemic. We need to keep parents and babies together. We have enough evidence in all the pillars that you mentioned that the parents are essential caregivers and then ICU for the babies, and you can never be seen as visitors. So I really appreciate the time that you took today to join us here. I know in Germany it's almost 8 o'clock right now. So I really appreciate your time today. Thank you.
Thank you so much. Thank you.
And for all of you watching us here today live on Facebook and YouTube channel, thank you so much for your participation, for your time to be here with us today. We'll be back in just a few minutes with Dr. Pablo Duran, talk about breastfeeding, nutrition, and the impact on the life course. I want to also thank our sponsors, Medela Water Wipes and Prolacta Bioscience, for their ongoing support. And CPBF is a registered charity, and 100% of all donations received this week will go to our support programs for families. To donate, please go to canadianpreemies.org and stay tuned, and we'll be back in just a few minutes. Hello, everyone. Welcome back to the Preemie Health Talks. If this is your first session of the day, welcome. This is our third day of bringing amazing speakers to share information and knowledge with you. My name is Fabiana Bacchini. I'm the Executive Director of the Canadian Premature Babies Foundation, CPBF, and your host for this event. The Preemie Health Talks is the first international live series that CPBF is hosting 2021. These educational sessions are in collaboration with the Family Integrated Care Committee, the Canadian Association of Neonatal Nurses, the Canadian Neonatal Network, the European Foundation for the Care of Newborn Infants, EFCNI, and GLANCE, the Global Alliance for Newborn Care. For those not familiar with CPBF, we are a charitable organization, and our mission is to empower families of premature babies every step of the way through support and education. We believe that through consistent information, access to helpful resources, and peer support inside and outside an ICU, we can empower families, ensuring they are ready to care for their babies. For these Preemie Health Talks, we brought health experts from around the world and from all over Canada. We've been diving deep into topics affecting preemie health, from breastfeeding to parental mental health during the pandemic, from the importance of kangaroo care to the best practices to protect your baby's skin. If you need closed captioning, you can watch it live from our YouTube channel and enable closed captioning on the screen. I want to thank our sponsors, Midela, Water Wipes, and Prolacta Bioscience for their ongoing support. And please use the comment area below your screen to share your comments, your questions, your perceptions, and your stories. So I had the first session today with Dr. Johanna Kostenser from EFCNI, talk about the global impact of COVID-19 on neonatal care. And right here now, we are going to talk about breastfeeding, early nutrition, and the impact on the life course. This session will review the evidence and importance of early initiation of breastfeeding and systems of care that can help on providing the best care and nutrition to preterm babies. This will be addressed by presenting the baby-friendly hospital initiative for small, sick, and preterm newborns recently launched. We will also analyze the potential impact of inadequate nutrition and other adverse perinatal outcomes on disabilities and long-term consequences. And I have here with me, joining live from Uruguay, Dr. Pablo Duran, who is a medical doctor and PhD from University of Buenos Aires. Currently, Dr. Duran is the Regional Advisor on Perinatal Health at the Latin America Center for Perinatology, CLAP, the Pan-American Health Organization for the World Health Organization. Dr. Duran is an Associate Professor from the Department of Public Health, University of Buenos Aires. He has more than 25 years of clinical experience as a researcher and expert in epidemiology, monitoring and evaluation of policies and population interventions in maternal, newborn, and child health. Dr. Duran, thank you so much for joining us here today.
Thank you. Thank you very much, Fabiana, for this invitation. And thank you also to CPBF and to the colleagues, families, and parents that are participating in this session. I am really happy to be in here. And if you allow me, I will share, I will share the...
Yeah, you can share your screen. And for all of you watching us at home or from the hospital, please send your questions and your comments, and Dr. Duran will address them at the end of his presentation. I don't see your slides yet, Dr. Duran.
Can you see them now?
No. I can share with you. I can share, and you just let me know when to move forward. No, they're not coming to the stream.
Not now?
Not now, no.
Okay. So
okay. I can share, and just let me know when to change the slides.
Okay, thank you.
You can go ahead. You can see you.
Yes. Okay, thank you. So again, thank you very much. And the idea of this presentation is sharing with you, as it was mentioned, the importance of breastfeeding and mainly of early nutrition and early initiation of breastfeeding due to the main impact along the life course. We can move to the next one, please. And it was good having the previous presentations, because many of the most important comments have been highlighted. What do we know today about breastfeeding? I would say, and I imagine you agree with me, that we have learned a lot. We have a large amount of knowledge about the importance of breastfeeding for the mother, for the baby, for the family, for the society, in terms of nutrition, in terms of health, in terms of facilitating and promoting the attachment, the maternal and newborn attachment, neurodevelopment, but also because breastfeeding protects against many health adverse outcomes, not only during infancy, not only during the first days or months of life, but also along the life course. And the evidence shows that even cardiovascular and other chronic conditions can be reduced and prevented if breastfeeding is initiated early and is the main source of nutrition for the baby for at least the 6 months of age. So, and we can move to the next one, please. So what would be the importance of talking about early initiation of breastfeeding during this presentation? Because in the contrary of what I have just said, globally, only 2 out of 5 newborns are breastfed during the first hour of life. And as Dr. Kostenser mentioned, there's and it's not only due to the COVID pandemic, it is something that comes from even before the starting the pandemic. And in Latin America and the Caribbean, around 50% of newborns are not breastfed during the first hour of life. The next one, please. And it has been seen, and this comes from an analysis performed by WHO and UNICEF, that even when early initiation is around 50% of cases in the world, the highest improvement has been seen in those health facilities in which the populations where the proportion of institutional deliveries increased. But the issue is that in most of our populations in Latin America and the Caribbean, it's not the same case in other regions, but it is indeed in our region. More than 90% of deliveries occur at health facilities. But still, we see that even when we know about the amount of evidence supporting breastfeeding, and that almost 95 out of 100 deliveries occur in health facilities, only half of the newborns are breastfed during the first hour of life. And what is the reasons, which are the underlying causes that explain this situation? If we move to the next one, we can see that some, perhaps many, in most cases, institutional practices not always are friendly for the mother, friendly for the newborn or for the baby, or friendly for the family. Here you have, for example, the proportion of birth occurring by C-section, which ranges which averages from 20 to 40% in general, but you can see a huge variation. And on the right side, the outliers showed in some cases that more than 80 or 90% of deliveries in some cases occur by C-section. And this is a condition that does not contribute to early initiation of breastfeeding due to the condition of the mother, due to the condition of the baby. So this is just a flag showing that institutional practices do not contribute many times on promoting early initiation of breastfeeding. The next one, please. You can see here, and this comes from the same analysis from UNICEF, that in green dots, you can see the proportion of babies that were breastfed, but you can see that even when they continue being breastfed, most of them, or large proportion, between 30 and 40%, in different socioeconomic conditions, receive not milk, or milk that does not come from their mother. So these are also interventions that, along with what we have mentioned about C-section, do not contribute for early initiation of breastfeeding. The next one, please. So what needs to be done in order to change this situation? Because we know that early initiation of breastfeeding is perhaps one of the most conditions that contribute to continuing and sustaining breastfeeding. Obviously, that requires a mother's agreement in order to breastfeed their baby. So there are different strategies and interventions that need to be done that will contribute both on the early initiation of breastfeeding, but also on sustaining breastfeeding. One that we have mentioned is the increase in health financing, and this means improving the spaces, the facilities, the resources for initiating and sustaining breastfeeding within the institution, but also to apply the code for commercialization of maternal milk substitutes, improving the quality of care within the health institutions, as we have already mentioned, improving the access to counseling services even prior to delivery, during pregnancy, in order to help mothers not only to learn in terms of the advantages and also the conditions or the things that mothers need to learn about how to sustain breastfeeding, the questions that mothers have, but also to empowering mothers and families in order to request and ask for that care, that friendly care that contributes on early initiation and sustaining breastfeeding. Also, strengthening links between health services and the community. And here is where parents association, parents networks, and family networks are important, because advocacy do not come only from international agencies, academic associations, or the academia. It's only the role of the families, the parents groups that can contribute on strengthening and implementing the interventions required to this early start and healthy start for every newborn. And finally, establishing surveillance and monitoring systems in order to learn about the practices, to identify the not recommended practices, and to promote modifying those not friendly interventions. The next one, please. And I'm talking from the regional perspective, from Latin America and the Caribbean, which may be a bit different than what happens in Canada, but we know that within countries there are groups that suffer from different conditions that expose them to specific risk that may adversely contribute to nutrition, growth, development, and well-being. And the Latin America and the Caribbean region has been exposed for a long time to adverse socioeconomic conditions. And since the very beginning of this pandemic, the CLAC, the Latin American Center for Economics, and PAHO has presented this document showing the important impact on socioeconomic conditions of the pandemic in the Latin American population. And this is something that we have to take into account, because the adverse socioeconomic conditions contribute to not sustaining breastfeeding, and at the same time, not breastfeeding contribute to adverse socioeconomic conditions of the family, because mothers and family have to face for providing other nutrients out from the maternal milk. So this is a cycle that in the region we need to take into consideration, not only at the individual level, but also at the regional level. The next one, please. And as Dr. Kostenser mentioned, and this comes from a survey, a global survey on the sustainability of essential services at the global level, we are at this time analyzing the second round of this survey. The results that I'm showing here come from the survey performed last year. And based on this survey, we could analyze the disruption of specific interventions. You can see family planning, prenatal visits, delivery, institutional delivery, newborn care, nutrition support, and you can see that around 50% of the countries express in some way the affection, the disruption of these services. So not directly related to COVID, but indirectly related, our communities, our families were affected by not being able to access these essential services. And breastfeeding is adversely impact on that. And if we see the next one, this comes from an analysis that we have just performed, and it's ready to be published and disseminated. Can we move to the next one, please? Here you can see this is from the regional level, which should be the potential impact of COVID-19 pandemic on the rates of breastfeeding from now and up to the year 2030. And you can see that if at the regional level the rates were as low as something over 30% of breastfeeding exclusively at the age of 6 months for effect of the pandemic, this prevalence, which is low, will be also even lower in the next 1, 2, or 3 years. So this will have a great impact in the newborns, in the babies and families that, as we mentioned before, will have a long-term impact. So our babies being born during this period need to be supported, and the families and the health facilities, in order to sustain all those essential services that can promote healthy lives. And breastfeeding, early initiation, and sustaining breastfeeding are one of these key interventions. The next one, please. Inequities are present in our communities. Just as an example, you can see here the differences in terms of the prevalence of prematurity between socioeconomic conditions at the global level and at the regional level, Latin America and the Caribbean, where you can see in some way that almost the prevalence of preterm birth may double in the low socioeconomic conditions. So those babies that, for the condition of being premature, are exposed at different risk, being born in communities, in countries with low socioeconomic conditions, expose them to additional risk. So it is important to every baby to be breastfed, but most in those preterm babies, and mainly those being born in low socioeconomic conditions, in order to promote the best nutrition and the best care for these babies. The next one, please. So we need to move from the institution and disease center to the person, in this case, newborn and premature baby, and family-centered care. So we need to stress that the important person here are the newborns and their families, and looking for the best care from the other sectors out of the health sector and within health sector. Health facilities, managers, and policymakers need to be aware of this situation, because they are the responsible with the direct care provided by parents and families to promote this best environment and conditions. The next one, please. So we know that most of the babies being born at term need the general care and not specific conditions. But in those cases where prematurity or other conditions make special needs present, specific services and specific care need to be provided. And in this case, I would like to stress again that providing maternal milk, even being breastfed or through human milk banks, or expressing milk and providing mother's milk to the baby, are the best interventions in terms of promoting adequate care to these babies. The next one, please. It's been a challenge at this time from the global and regional perspective to work on those small and sick babies, and with WHO and UNICEF, we are promoting this specific approach. And linked to that perspective, the Baby-Friendly Hospital Initiative, adapted or looking specifically for preterm babies, has been developed and launched last year. And the following slides, we can move to the next one, stress the importance of addressing the main topics that are considered in this initiative: promoting skin-to-skin care, establishing and maintaining maternal milk supply in the way that is possible for the mother and for the baby, and facilitating the space utilization within the institution. Rooming need to be sustained unless a medical condition indicates that the baby needs to be allocated in an NICU and in another space, not with the mother. But in that case, and it was discussed in the previous session, there's an important need for providing a space for the newborn and for the mother to stay together, to allow the family to go to stay with the baby and to provide the care and the nutrition that is required. So this means adequating the institutions in terms of the health space, the physical space, but also the rules and the norms allowing parents and mothers to stay with their babies. The next one, please. And I mentioned before the importance of key indicators for surveillance. And this baby-friendly initiative for small and sick newborns highlight the importance of collecting and monitoring indicators at the individual level and at the facility level. At the individual level, the growth patterns of the baby, the feeding practices, sustaining skin-to-skin care, the results from the laboratory, clinical diagnosis, and maternal milestones of measures. And why I'm mentioning this? Because it's important for parents to be aware of the conditions, and these are the main information that need as empower, as a co-providers of care, need to be aware, need to learn, but also need to ask for this information to the healthcare providers, and also promoting, collecting, and informating this information. It's a key role for parents individually and as organizations. The next one, please. But even when the regulations and recommendations are in place, there are many measures that are not being accomplished, and this comes from an annual survey on the attachment of the recommendations of the commercialization of subsidiaries of maternal milk. And we can see that many countries, you can see 31 countries, have legal measures covering the full breadth of breast milk substitutes, but many countries do not have these kind of regulations, or for earlier or younger babies between 12 and 35 months of age. 81 countries cover complementary foods in other regulations in terms of advertising and promoting their use, but still there are many violations of the regulations and norms that are promoted by the code. So it's important for parents and for associations to be aware of the norms and regulations within these international norms. The next one, please. You can see here the proportion of countries that responds that the key code provisions are not addressed or are violated. Those that are underlined as key provision of national legal measures, the provision of gifts or incentives to health workers, or the sponsorship of meetings of health professionals or scientific meetings, and nutrition and health claims are those that are least addressed at country level around the world. So the next one, please. So, and I'm finishing. So within the health system, the quality of care relies on two main pillars. One is the provision of care, which is responsibility of the managers, of the policymakers, and the health team, and imply the implementation of evidence-based practices to provide information and to adequate the system and the functional based on that evidence. But on the other side, we need to identify at the same level and with the same importance the experience of care of mothers, fathers, parents, and primary care providers. So both the health system and the families are contributors to the quality of care. So it's important to be aware of what is the best way of providing care, which is the best way of nurturing our babies. And we know that nurture is not only providing food, providing nutrients. It's also about providing quality of care, providing attachment, being present, and within this context, early initiation and sustaining breastfeeding is the most important initial intervention that need to be provided. And if those pillars, the quality of care provided by the health facility and the commitment and active involvement of parents with knowledge, it's present, the results will be important in any condition, and mainly in those newborns who are born sick, small, and with special needs. So the next one, please. So we know that different actors, different settings, and different interventions come together in order to promote and provide better results, or if they are not adequate, the consequences will be adverse outcomes. These different actors, settings, and interventions are related to the health services provided, the decision makers and managers at the different levels, the need for legislation, and this is important, the last but not the least topic, which is the society, the community, and the family, to learn, to be aware, and to promote that legislation, decision-making, and management of the health system be aligned with the best practices and with the best evidence in order to achieve the best results expected. So the next one, I think it's the last one. So, oh, I'm sorry, the title is in Spanish, but what we know and what is missing, it's what we try to discuss during this session. There's a large amount of knowledge about early initiation of breastfeeding and the long-term impact, but the missing part is addressing the regulations, the norms, and implementing the knowledge that we already have. This is related to institutional structure and sometimes fragmented interventions, and thinking only on specific and high-tech interventions. We forget providing the first level of care, which is the most important, and I'm talking about, obviously, about breastfeeding. Inequity and inequality that are present between countries, but also within countries and within communities. The perinatal situation and the impact along the life course, we know that those conditions adverse at birth that are not being adequately cared, nurtured, and provided the best care will have impact in terms of disabilities and the loss of human capital and social capital. So we need to stress the importance of person-centered care, sustaining and strengthening surveillance, monitoring, and asking for the key information and for accountability, and thinking from the rights and equity perspective. So it's the responsibility for each of us, independently of the role and the experience, but the responsibility for everyone to provide this comprehensive care and sustain in evidence. And the most important intervention that I addressed during this presentation is starting breastfeeding during the first hour of life, which will contribute on an improvement in the results, mainly for prematurity and sick newborns. I think it's the last one. We go to the next one. Yes, thank you. So the adverse perinatal conditions are the expression of inequity and at the same time cause of greater inequity in the life course. So I hope that we all together can work on improving these conditions and promoting early initiation and sustain of breastfeeding. Thank you.
Okay, Dr. Duran, thank you so much for your presentation. You always bring this macro picture that we all need to understand, like from the big vision to where you're doing the work in our own countries. Because as you mentioned, there is so many inequities, inequalities within the countries. And I can see even in Canada, where everybody in the world looks, okay, this is a developed country, everybody has the same access, but we don't. Like families who live in rural areas, indigenous people, they do suffer a lot with our access to care. So I think my first question to you is, because obviously you're talking about standards and promoting attachment, sustained breastfeeding by having the family present and involved. And we also heard earlier today on a survey done on an international level of all the restrictions in ICUs around the world at this time. And, a year later, we're still facing restrictions. So how can we change that? It is a big work, right? Unit by unit, but how can we show that the importance of parental presence and engagement, it is necessary for the life course of the child?
Yes, this is an excellent question and also a difficult task. But I think that in that case, it is really essential the parents' associations, parents' group, to raise their voice in terms of working with legislators, managers, policymakers, in order to promote modifying, as I said, physical the facilities from the physical perspective, but also including regulations and norms, not to restricting the entrance to the NICU just for 1 hour in the morning and 1 hour in the afternoon. Parents have the right to be with their babies. We know that the resources sometimes are scarce, the physical space is not best, so that needs investment, that needs the decision makers to make the changes that are required. So this is a long-term work, but it's important to have the evidence and to go with the rights declaration, with this technical information, and try to find a way of promoting these interventions from those actors.
Absolutely. Okay, Dr. Duran, you are frozen. Okay, you're back? Yes. I think my next question is in terms of sustaining family-centered care, because there is this conversation going around if, when, or how we are going to reintegrate families in the care of their infants in hospitals around the world. So how do you see the future of family-centered care moving forward beyond the pandemic?
I see, and from the United Nations and the different international agencies, the active participation of the community is being day by day and in all the documents being present. So I see a promising future, and it's important that, as I said before, the parents' associations raise their voice, and from the international scenario, the place and the voice is being facilitated. So I hope that in the near future, each country has their own parents' associations, and even that those parents' associations be linked in order to learn from each other, share experiences, sharing materials, and to promoting that care, and to being at the same level, as I mentioned, the two pillars of health facilities and community, be real, be a reality in terms of guiding the care and providing the care to the newborns.
Absolutely. I think there is a movement happening with parents' organizations around the world that was initiated by EFC and I, and we just saw Dr. Constance presenting today, and Glenn's is here. So we are joining a lot of, bringing actually a lot of parent organizations together to advocate on a global level for best care. So we still have a lot of work to do for sure, but I think we set the foot on that journey, and I think we have to just look forward from here.
Yes, I absolutely agree, and we are always open to participate in these sessions and in other discussions in order to promote well-being of our babies and families.
Absolutely. So in one of your slides, I was really fascinated because you show the difference between the C-section and a vaginal delivery and the difference on the initiation of breastfeeding. Why do you have such a difference?
Because the higher the prevalence of C-section, the lower the early initiation of breastfeeding. As I said, because of the mother's condition, the newborn, because babies are separated until maternal recovery. So early initiation does not start, and then this is a risk factor for not sustaining breastfeeding. We know, and it's a global movement in terms of reduce the prevalence of C-section. We know that there are many differences between socioeconomic levels in terms of eligible or not eligible C-section. Perhaps obstetricians have a better explanation than me, but the issue is that C-sections are sometimes in extreme not necessary and put at risk for the mothers, for the babies, and also contribute for not providing early initiation of breastfeeding. So this is something that it's important also to discuss during the prenatal counseling in order to discuss the potential risk and the potential consequences of C-section and the importance of early initiation of breastfeeding. So this is important also to be discussed and to develop materials for advocacy and on that regard.
Absolutely. And I think there has to be a lot of education, because I delivered my preterm baby here at 26 weeks through an emergency C-section. But right after my recovery, the nurse already brought the double breast pump. So I had to start pumping right away, which was a little overwhelming because I had just delivered prematurely, unexpectedly, through a C-section. But the importance of that moment for me, and today, obviously, I have the knowledge to know how important it was. But back then, she said, this is going to be good for your baby. And that's all I need to hear to start pumping. And I think this is a kind of conversation and education from nurses to parents that have to occur, especially in those unexpected moments. Because one thing is, you're going to deliver early. There is a precondition, or if you schedule C-section, but in those emergency situations, the education always going to be the key and should lead the parent in that direction. One question for you in terms of sustaining breastfeeding, though, because here in Canada, we have a year of parental leave, which it supports the parents at home who choose to continue breastfeeding. How about in other countries where we don't have that privilege of having that extended parental leave?
Yes, this is very important topic, and this is why legislation is absolutely important. And the Canadian situation is not the case in most of the Latin American and Caribbean countries. In some countries have only maternal leave. In other countries, maternal and parental leave, and the length of that leave is most of the time mostly shorter than 1 year. And there is another issue. I have read a paper 2 weeks ago about the importance of informal market and the mothers working in the informal market and sustaining breastfeeding, because legislation can apply for those mothers with a formal being involved in informal works. But we also know that in Latin America and the Caribbean, the proportion of population living under conditions in which informal work are the most common, those mothers even are not receiving the benefit of even a short leave. So the two issues are important. How to extend the leave for sustaining or for promoting sustained breastfeeding, but also how to protect those mothers in which this legislation does not impact because they are out of any legal regulation.
Absolutely. Yeah, there still have a lot of work to do, Dr. Duran, but I'm so grateful that you join us here today and you share all your experience and expertise with our population. So thank you, and I do hope you come back and share more with us.
Absolutely. Thank you very much.
Thank you.
Thank you.
And for all of you watching us here today, live on Facebook or YouTube channel, thank you so much for joining us, for participating in the conversation. And if you missed a talk from Monday or Tuesday, our first 2 days of the Preemie Health Talks, or the first talk of the day today, you can watch the recordings on our YouTube channel, or next week they'll be available on our website, which is right here, the CanadianPreemies.org. And I want to thank our sponsors, Medela Water Wipes and Prolacta Bioscience, for their ongoing support. And CPBF is a registered charity, and 100% of all donations received this week will go to our support programs for families. To donate, you can go to our website, CanadianPreemies.org. Together, we can create a brighter future to all premature babies and their families. And tomorrow I'll be back addressing mental health with Kate Robson. She'll talk about foundations of well-being, daily mental health practice for NICU parents. And also I have Kelly Posey, who would be discussing trauma-informed care and trauma-informed care plans and how to incorporate these tools in their NICUs. So thank you, and I hope I see you tomorrow. Stay well, everyone.